So thank you for inviting me, Barbara. My name is Lucy Keating. I'm the team manager for the Psych Liaison team at Imperial at St Mary's. But I've come from Chelsea and Westminster and Northwick Park, and I've had over 10 years experience of working in Psych Liaison. And feel quite privileged to be able to speak here, kind of listening to what everyone is saying, because what I've been asked to talk about is how RMNs are working, and what do I think the ideal of what RMNs would be working in the emergency department. Apologies, I didn't provide any slides. It's been a bit busy here at Imperial the last few days, and didn't quite kind of get that together. But I just wanted to kind of touch on some of the points that Barbara and Mark have already kind of mentioned about the environment, about kind of how we engage with this kind of group of patients who we know trigger us, who we know make it difficult sometimes for us to do our jobs on a day-to-day basis. But what are we actually asking these RMNs in our department? What are we actually asking them to do? Within the QIP, it kind of asks about observations. It asks about kind of what the kind of care should look like. What does compassion look like? And when I read this, I kind of went back to kind of some of the basics of nursing care, of what that actually feels like. Do we triage? Do we actually take what these patient group are saying seriously? Yes, you know, we have this high intensity user kind of group of patients as well. Are we dismissive of them? But actually, what are we actually asking for this RMN group to do? Do we make them feel safe? Do we make this patient group feel comfortable in our emergency departments? And how do we go about doing that? One of the things is about one-to-ones. We've mentioned, I know that kind of there was a conversation earlier about kind of should, you know, if people suggest 15 minutes, where should that nurse sit? You know, should they be in eyesight? Should they be kind of behind the door? And what actually does that really? And I think what we really need to do is speaking to our liaison colleagues of actually being a bit more descriptive in what we're actually asking for, because I think actually we need to make these decisions collectively and really together. Again, it's about these RMNs building a rapport with this patient group, making sure that they can speak to them. You know, are they agitated? Are they being their advocates? And what, again, does that look like for that patient? You know, if they're able to build a rapport, do that then help them with their physical aspects of their physical care, such as then are they able to get the ECG from them? Are they then able to get the bloods from them because they've taken the overdose and we're still waiting for the bloods and the NAC treatment to start? You know, how do RMNs behave in the department? And I think we need to kind of go back a stage, because actually, are they seen as part of the team? Are they part of the ED team? Are they actually really recognized as a member of staff? You know, do they wear the uniform? Do they not wear a uniform? And how does that actually fit into kind of the structure of the ED team? We've spoken about you know, the observations, and I think again we really need to kind of think about, you know, the RMN's approach. We've all possibly, in all the departments that people work in, you know, the RMNs that we rely on, the ones that are good, the ones that, you know, we can really rely on. But actually, what about the other group of staff? And what do they need? What training do they need? What, you know, are they actually given the tools to be able to do their job effectively? And I think that's really important. When we talk about kind of RMNs and observations and everything as well, we kind of talk about kind of the rooms that these patients sit in. And again, I know that Mark touched on it with some of the pictures of kind of some of the rooms that they have in his department. But again, are we, is that the same in every department? You know, the room that is kind of has been trashed by a patient 4 weeks earlier, has that been repaired? Has that seat been looked after? And if not, why not? Because why are we keeping, or why are we thinking that we're looking after this patient group differently than we would for any other patient group? And I think those kind of things are really important. Engagement with the RMNs, you know, again, the environment, the room, but also EDs are noisy. EDs are busy, chaotic, Barbara started this presentation by kind of saying things are a bit chaos at the moment, and that's a perfect word to kind of describe some of the EDs at various times of the day and night. And here we have a patient who's in crisis, is really struggling, and the lights are full on, there's bleeping everywhere, there's people talking everywhere, and actually, do we really think about what that calm environment looks like? Can we switch the lights down in the certain rooms? And I know it's an AED, we shouldn't really be having to think about these things, but actually, as we all recognize, patients are spending longer and longer in the departments for whatever reason. I don't think it's just beds, but numerous other things. And again, I think we just have to acknowledge this and recognize this. The age-old argument about whether we're allowed patients out to go out and smoke, get fresh air as well, I think is quite contentious at times. And I do worry that we kind of lose focus on what that actually means for some of these patients. And I completely agree with Barbara, do we actually really think about this patient as a whole? And should we be, thinking about nicotine replacements and all those kind of things? Because actually, we would for anyone else. So why aren't we for this group of patients? I think one of the really important things for our RMNs in our departments is being our patient's voice, being that advocate. And again, Barbara and Mark both touched on it earlier about making sure that patients are getting their regular medication. Why would we not want that to happen? Why would we not give their patients their regular meds? And if not, we're not giving it, why are we not giving it? And, again, seeking help from our psych liaison kind of colleagues about that. An advocate about what their rights are. We have this huge grey area about kind of whether they're detained, not detained, and what that looks like. And again, being that, giving that information, as Mark said earlier, about kind of making sure that these people are really given all their information that they need, because we would be for other patients. And so again, why is this different? And engagement, and what does that actually look like in regards to kind of working with a patient who is going to be there for a long time, and what does that actually mean? Do we sit down and I know that some of the work we're doing here at Imperial is looking at what IT things that we can be giving to patients, whilst they're sat in the department, and looking at, some of the self-help things and some of the, through kind of social media and everything. But we also have a Red Cross worker who works in our team who actually is able to kind of look at some of this kind of the social aspects of this. And again, bringing that in at this very early stage, I think is really important. I met with one of our service user people that we kind of do a lot of work with within the trust that I work in CNWL yesterday. And I just asked her what her kind of thoughts about RMNs in the department were. And this is somebody who's got lived experience for herself and for her daughter. And kind of her resolving kind of themes were, they need to show compassion. They need to show that actually they've come to the right place to get help, and that's okay. Even though, lots of people at the moment saying, ED isn't the right place for, mental health patients, that they weren't turned away, they were taken seriously, and they were listened to. And I think that's a really important take-home message, that, the lights are always on, in the emergency department, and people are always there to listen to them. And I think that's, really, really important. That's it.